Obstetric Anesthesia, Diseases in Pregnancy 4, Hernando de Soto. Lecture modules, we'll be looking at miscellaneous diseases. Question. Laboratory test results in the obstetric patient with thyroid disease may indicate which one of the following. A. Elevated thyroid stimulating hormone or TSH and high FT4 indicates disease in the thyroid gland. B. Screen all obstetric patients for thyroid disease. C. Low TSH and low FT4 indicates a hypothyroidism due to a problem in the pituitary gland. D. Low TSH and elevated FT4 is found in patients with hypothyroidism. E. Low TSH and low FT4 indicates disease in the thyroid gland. The correct answer is low TSH and low FT4 indicates a hypothyroidism due to a problem in the pituitary gland. A is incorrect since high TSH and low FT4 signifies disease in the thyroid gland. B is no longer done as per the American College of OBGYNs. D occurs in hyperthyroidism, and E occurs in the disease of the pituitary gland. Question. A 30-year-old female presents to the operating room for an elective cesarean section. Past medical history is significant for hyperthyroidism. Which of the following best describes this disease? A. Hypometabolic and hypodynamic state. B. The use of beta blockers is contraindicated. C. Unless it's an emergency, the patient needs to be euthyroid. D. Low output cardiac failure. E. Thyroid storm is not a concern in patients for laparoscopic surgery. The correct answer is unless it's an emergency, the patient needs to be euthyroid. This best describes the handling of the patient with hyperthyroidism. Again, A is incorrect because hyperthyroidism is a hypermetabolic and hyperdynamic state. Hence, beta blockers usually can help, and B is incorrect. D is incorrect since it's a high output cardiac failure. And E is incorrect. Thyroid storm is always a concern in patients with hyperthyroidism. E should say there instead of D as the last statement there. Question. 24-year-old female, 38-week pregnant, presents to the labor and delivery suite in labor, actively contracting. The patient requests an epidural for her pain. She has a history of insulin-dependent diabetes. Which of the following best describes diabetes in pregnancy? A. Lower incidence of cesarean sections. B. Increased gastric motility. C. Insulin does not cross the placenta. D. Oral hypoglycemic agents do not cross the placenta. E. Lower vasopressor use. The correct answer is C. Insulin indeed does not cross the placenta and is the treatment of choice for diabetes in pregnancy. C is again the correct, and the reason it does not cross the placenta is because of a high molecular weight. A is incorrect since they have a higher incidence of C-sections. B is incorrect. They have gastroparesis with a higher incidence of aspiration. D is incorrect since they have a propensity to cross the placenta. And E is incorrect because of an autonomic neuropathy with use of vasopressors being higher. Endocrine OB patient, the pregnant patient with thyroid disease. According to the American College of Obstetrics and Gynecologists guidelines, the most recent guidelines from 2015, it is believed that no screening needed any more than the general OB population. The thyroid stimulating hormone is the TSH, first-line screening test if suspicion of thyroid disease. TSH along with free thyroxine 4 or free thyroxine index Free thyroxine index is an estimate of the free T4 concentrate, and its calculated value is determined from the total T4 test and some estimation of the level of thyroid hormone binding protein. Elevated TSH and a low FT4 indicates primary hypothyroidism due to disease in the thyroid gland. A low TSH and a low FT4 indicates hypothyroidism due to a problem involving the pituitary gland. And a low TSH with an elevated FT4 is found in individuals who have hyperthyroidism. What is the anesthetic management of the pregnant patient with thyroid disease? Obviously, favor regional anesthesia. Will be much better from a hemodynamic perspective. Cardiodepressant effects of anesthetics may influence here with decreased preload, decreased cardiac output, and a blunted baroreceptor response. Be careful because they're very sensitive to anxiolytic agents and sedatives, so caution with their use. And these patients have a tendency to develop hypothermia, so I would avoid hypothermia in these patients and the hemodynamic consequences that can cause. What about the patient with hyperthyroidism? These patients need to be euthyroid if possible, because of the potential for thyroid storm, hypermetabolic and hyperdynamic state. So these, everything in regards to hypermetabolism can happen. Hypertension, tachycardia, and tidal CO2 issues. Beta blockers and antithyroid drugs may be used in these patients, or they can come to the operating room with these drugs on board, and obviously the potential for us with their side effects and interaction with other drugs, and the use of magnesium also in these patients. If they're not euthyroid, for example, if they require urgent emergency surgery, trauma patients, for example, these patients can be very difficult to manage because of their hyperdynamic circulation. They can have high output cardiac failure, potential for cardiac dysrhythmias, may have goiters or neck masses with the potential for difficult airways. Obviously, the worst scenario is the potential for an intraoperative thyroid storm, in which case drugs like propylthiouracil, sodium iodide, steroids, beta blockers can be of utmost importance in these patients. Moving on to diabetes, is a disease with autonomic neuropathy. These patients may need higher vasopressor use. Obviously, these are patients that are already at increased risk of aspiration, so now you're adding another more fuel to the fire with gastroparesis to have a higher incidence of C-sections because of big babies. If in need, the best is to use insulin because of its molecular weight does not cross the placenta. And that would be the best drug to use if needed. 7% of all pregnancies develop gestational diabetes, usually in the second or third trimester, but this will go away with delivery. Beware, especially if you practice in a place where there's no neonatologist or pediatrician available. Newborn can be hypoglycemic, and babies of women with pre-existing diabetes are more likely than other babies to be more sensitive to hyperglycemia, have heart defects, neural tube defects, and other issues. Pheochromocytoma is another endocrine obstetric situation that can happen and may require tumor resection early in pregnancy, C-section followed by tumor resection. General anesthesia, an neuraxial block, or a combination have all been used successfully in these patients. Amniotic fluid embolism is a potential complication of pregnancy, and it triggers a significant reaction that can lead to cardiorespiratory collapse, massive bleeding, And a lot of researchers, a lot of publications recently point to the fact that it's not true embolism, but it's actually an immunologic phenomena with similarities with anaphylaxis. Treatment supportive, again, if there's cardiorespiratory collapse, intubation may be needed with inotropic support, this is not a very frequent situation, so obviously it's important to think of differential diagnosis with venous air embolisms, etc., and some more novel treatments of nitric oxide and even ECMO. Moving on to thromboembolism in the obstetric patient. Remember, pregnancy is a very hypercoagulable state with the potential for deep vein thrombosis. So thromboembolism is a true and very plausible situation that can happen in obstetric. The risk is much lower with regional anesthesia. Remember, pulmonary embolus, it will cause a sudden drop in end-tidal CO2, suggestive of increased dead space. Respiratory alkalosis and hypoxia may be there, but usually ABGs are not very helpful. And if you get questions on EKG in this scenario, there's S1Q3T3 in less than 20% of cases. This means S wave in lead 1, Q wave in lead 3, and T wave inversion in lead 3. Easy way to remember that as an acronym is S1Q3T3. Moving on to malposition and malpresentation, breech presentation. These are the varieties of breech presentation. The complete breech on the left here, the incomplete breech, and the frank breech. Maternal risk factors, contracted pelvis, uterine shape abnormalities or other situations like tumors, tumors causing compression, extrauterine, patients on their 5th, 6th, 7th pregnancy. There's also placental fetal risk factors, placenta previa, amniotic fluid issues like oligohydramnios, fetal prematurity, which is the most common in over 30%, and multiple gestations. Transverse lie, again, prematurity, polyhydramnias, anomalies of the uterus, placenta previa, etc. 80% of cases occur in women who are para 3 or more. Lupus, antiphospholipid syndrome, conform part of the autoimmune disorders that can happen in the obstetrical population. Obviously, these are patients that may have a lot of comorbidities. Obviously, it depends a lot on the severity of disease, where could be renal involvement, the so-called lupus nephritis. These patients many times are taking immunosuppressants and with potential drug interactions. They may have issues like subglottic stenosis and laryngeal edema with potential difficulty airways or difficult airways, and they can also have some coagulation issues there. Sickle cell anemia, epidural or neuraxial anesthesia is pretty awesome for pain control, especially during labor and during crisis. It also decreases peripheral venous stasis and maintains uval. These patients, we need to maintain euvolemia and normothermia. Anticoagulant therapy for the obstetrical patient, prophylactic regular heparin is not contraindicated. The so-called 5,000 units sub-Q that you will hear a lot of obstetricians ask you for enoxaparin or Lovenox, we need to wait 12 hours after the last dose and wait 24 hours after dalteparin or low molecular weight heparin. Again, this is for placing or removal of epidurals. Rh incompatibility, mother Rh negative and baby Rh positive, usually happens in second pregnancies and beyond. Needs to be detected early in pregnancy and controlled because of the potential for hemolytic disease of the newborn that can present in the newborn with potential brain damage, heart failure, and even death. ABO incompatibility, more frequent than Rh incompatibility and not as serious. Mother blood type different than the baby, can cause some hemolytic disease of the newborn with jaundice needing some treatment, albeit rarely exchange transfusion. HIV infections, if you are called to, for example, place an epidural in a patient that is HIV positive, there are already HIV particles in the CSF at initial infections, so spinal epidural is okay since HIV is already present in the central nervous system. There's usually no neurologic implications after delivery, and the overall treatment of these patients is the same as a non-infected parturient. Thank you very much.